Okay. Um, okay. So just again, we're just starting here. When for these modules, it's one of the essential knowledge that you need to know. You won't be questioned about it because it's straightforward, but understanding it will help you for later modules. So ventricles, if the problem is ventricular problems where the ventricles are unable to push the blood, then the symptoms will basically manifested by or manifested with the with the system that's behind the ventricles. For example, if the patient has left ventricular heart failure, then what is before the left ventricle? Again, it's the right, it's the left atrium that's connected to the lungs. So that will be a congestion problem. So again, if the left ventricle cannot push the blood, then the manifestation will be behind because of the congestion. You can think of it of a traffic. That's why the left ventricular heart failure usually you show symptoms of pulmonary. The same thing with the right side. If the right side cannot push the blood, then the blood will back up, and you will see the symptoms be whatever the system before the right side of the heart, where you see it as peripheral edema and ascites and systematic. Now, if the problem is the other way, if there's something wrong, like let's say if there's a clot, or if there's a valve problem, let's say there's a clot, there's atrial fibrillation in the left side, and the left side, which is the right atrium, left atrium, send the small thrombi down to the left ventricle. Now, if the left ventricle is functioning fine, but the problem is in the blood, there's a clot, then you will see the manifestation of that problem in whatever after the ventricle. So, assuming left ventricle is fine and there's just a thrombi because of fibrillation, then the thrombi will go to the system. It'll go to the brain or to the kidneys or to the heart. And if it's in the left, if it's in the right side, if the right side, the ventricles is fine, pushing fine, but the problem is thrombi, then the thrombi will be pushed to the lungs, and then you will see manifestation in the lungs. So that's how the physiology and the anatomy can help you understand later. So as you know now, when we ask you to differentiate between left-sided and right-sided, you don't need to memorize. But when you understand that right-sided is connected to the vascular system, so if the right side of the heart cannot push the blood, then you see peripheral edema. And then the opposite will be for the left side. If the left side is not working, then you will see the problem in the lung, and so on. Okay, we talked about the cardiac cycles and how the automaticity and all the characteristic of the myocyte make it able to fire at a specific rate. And we talked about the cardiac circulation also and how important the coronary arteries are, and the that it later explains the manifestation of coronary artery disease when there is an occlusion, or whether it's partial or complete occlusion in the in the coronary arteries, and how that can develop to ischemia or injury or necrosis. And we talked briefly about the conduction system, and you needed to know that what the SA nodes is, the pacemaker, the natural pacemaker, what's the function of the AV node, and how the electrical impulses transmit to the rest of the heart. And that if the impulses start in the SA node, then we call it sinus. If it's a problem AV node, there will be AV problems. If you see it in the ventricles, that manifests as a QRS problems, and so on. And the heart layers, again, this is just more anatomy. So later next week, when we talk about endocarditis and myocarditis and pericarditis, you will understand where the problem is, because it depends. Again, if it's pericarditis, it's more of restriction. If it's a myo problem, it's more of the muscle pushing problem. If it's endocarditis, then it's mainly inside and it's connected to the valves. So the position or the location of each one of these layers is also important, and will explain the pathology later. So make sure that you understand these concepts. Okay, now the hemodynamics. Now these terms that there are a few terms that you have to understand by now, because you're gonna hear it over and over and over in your courses and in the hospital, and they should make sense. And again, you should start using these kind of terms. For example, the major ones are preload, And just to help you, remember pre means before, and load, you are loading something. So what we are loading here is the blood. So this refers to loading blood before it's being pushed. And so mainly what you, when we talked about preload, we most likely means the preload in the right side of the heart, because that's where it's fair, that's how we are able to measure that easily. So as you know, all the venous blood comes back to the right side of the heart first in the right atria, and it's then released to the right ventricle, pushed to the pulmonary circulation. And then, so, and also the left side of the heart, the load, again, the blood is loaded in the left atrium after it's get oxygenated in the lungs. So also there's a preload for the left side of the heart, but we don't measure that usually. It's more of invasive. But so if you hear the word preload, we mean by it the volume of the blood, or the pressure that the left okay, the preload, the right ventricle preload means the pressure that the venous return will create on the right and the right ventricle as a result of the filling. And now, what is the significance of that? That's what we care about more than the definition. But you need to know that this is what it refers to, and the clinical significance of that is that it is the major indicator of the fluid status. So when this number, the preload, is high, that means that the patient has too much fluid. If it's low, it means that there is no enough venous return, and it could be because of dehydration, or maybe the blood is not coming back. There are some conditions where the problem is massive vasodilation, and that vasodilation keeps the blood away from the heart. There's no vasoconstriction or strong vasoconstriction to bring it back. So anyway, when you see a preload, we refers to it to again the venous return. If it's low, that means the venous return is low. Now, clinically, that is measured by what we call the CVP, the central venous pressure. So you need to connect all these terms together. So preload, by definition, that's the definition. By clinical measurements or objective numbers will be the CVP. And by physical examination, you will see symptoms like JVD. So every time you see a JVD, especially if it's at the 45 degrees, you need to understand that it's most likely the CVP is high, or the venous return is high, or the preload is high. It's all the same meaning. Now, what is also um, the significance of the preload also, again, if the load in the right, I mean the cardiac output that leaves the left ventricle depends on the preload that starts at the right atrium, because it's a one circulation. So if we have enough preload that goes to the right atrium, down to the right ventricle, to the pulmonary circulation, to the left atrium, down to the left ventricle, then we will have normal cardiac output. If the start is low, the end will also be low. So if the preload is low, the cardiac output will be also low. So that's another uh, clinical significance for the preload. The other thing that you need to know also, the cardiac output, and that it's basically depends on stroke volume. Now, stroke volume again depends on the preload. So if the preload is low, then the stroke volume is low, and that's why the compensation for dehydration or for low CVP or low preload or low stroke volume will be to increase the heart rate. The other term is the afterload. Okay, now from the name again, after what? After we loaded the blood, and we load the blood in the ventricles. So now the ventricles are ready to push the blood. How much pressure do they have to assume to overcome the resistance in the blood vessels? Because that's how the blood moves. The ventricles will push the blood in the blood vessels. You can think of pump and hose. Okay, so it depends on the diameter and depends on the structure of the blood vessels. The ventricles will have to push. So you can think if there is a vasoconstriction, or if there's a problem, if the blood vessels become hard, anything that increase the resistance inside the blood vessels will increase the afterload, which is the pressure again that the ventricles will have to assume to push through the blood vessels. Okay, so you need to understand that again that vasoconstriction will increase the afterload again because they make it harder on the ventricles. And if you have a vasodilation, it will be the opposite. Vasodilation decrease the venous the resistance, the systemic resistance we call it, and it becomes easier for the ventricles to push. Again, there's also a connection there with the cardiac output. If the resistance is very high, and then the ventricles will have to work harder, and they may not be able to push the whole amount of blood that was loaded. So it's possible that severe vasoconstriction, for example, will also decrease the cardiac output, while vasodilation, when it's easier for the ventricles to push, will also make it easier, and that will increase the cardiac output. Now, I could replace cardiac output with ejection fraction. That's another way to measure the cardiac output. So if just you need to think of the concepts map. Cardiac output means the amount of blood that leaves. That could mean stroke volume. That also ejection fraction and so on. So now you understand that vasoconstriction could decrease cardiac output as a result of increase in the venous resistance in the blood vessels. And if the question asks you, how about ejection fraction? Same thing. Ejection fraction is a measurement of the cardiac output also. So also ejection fraction can be affected by the vasoconstriction and vasodilation of the patient. And that's why when we say ejection fraction between 50% to 70%, because we find it depends on the conditions of the blood vessels of the patient, and sometimes the same patient. Now, not every vasoconstriction will decrease or significantly decrease the cardiac output. That's why we have a range of everything. But we all have vasoconstriction, vasodilation throughout the day. Depends on the conditions that we go through. Whether the room temperature or if it's cold outside. But that still will keep the cardiac output within normal. Now, if it becomes severe, like in some cases like sepsis or anaphylactic shock and so on, that's when you can see a significant decrease in cardiac output. So again, the relationship between the blood volume, resistance of the blood vessels, and the cardiac output is important. You need to know that. Okay, let me just run this and see if there's anything else I want to cover. Okay. Now, just reminders. Let me go back here. Okay. Troponin. Now, you know why. I mean, again, troponin is the most sensitive enzyme that we will use to decide if this an MI or not. And you can see from the location of the troponin, if it's released, that means there's an injury and there's a decrease of vasculation to the myocytes. Okay, so again, troponin, if it's positive or if it's high, it's an MI. If it's not, then it's not an MI. Okay, and we talked about the ANB and a PNB, where the BNB is coming from the ventricles. So now you know that when the BNP is high, then that's a bad indication for that the left ventricle is, or the heart failure is getting worse. Okay, so that will be our mirror or our baseline. Whatever the BNP patient comes with, then we would follow that. So let's say again, the diagnostic tests are not only just to diagnose, but also to evaluate the treatment, and that goes with any disease. So if the patient comes with high BNP, we know that high BNP means that the patient heart failure is worsening. And if we do a treatment for the patient, we repeat the PNB in a couple of days, and if the BNP is low, is going back to normal, then that's indication that your treatment is good. Now, one of the questions that you will be seeing based on your clinical judgment, you may have, let's say, a patient with heart failure or a patient with MI, let's say heart failure, and then you will get a schedule or a table of results of the patients before and after. I will put a date of the admission and, for example, a date after 3 or 4 days, and you will see numbers. So, and you might be asked to pick which of these numbers indicates that the treatment is successful, or the opposite, which of these numbers indicates that the treatment is getting worse. So, for example, if the BNP was 2000 and now the PNB is 500, that's a good indication. That means that your medication is working. If and so on, ejection fraction was low and now is high, that's a good thing. If it's the opposite is a bad thing. Urine output is low, now it's back to normal, that's a good thing. Edema was 2 plus, now it's 3 plus, that's a bad thing, and so on. So you should be able to judge what is getting better and what is getting worse without memorization, but by understanding that edema is a bad sign. If it's getting more, if it's getting bigger, that's mean it's the condition is worse. If it's go down, that's a good indication, and so on. Okay, same thing with the preload, with the afterload, with the ejection fraction, with the cardiac output, with heart rate, with blood pressure, any sign. And that's why it's impossible to memorize all that, but you have, if you understand three mechanisms, you'll be able to understand how every signs and symptoms is correlated to a condition. Okay, we talk about the nitric oxide, and the major effect of nitric oxide is that cause vasodilation. It's naturally in the blood vessels, but if the patient doesn't have enough or doesn't make it, then we have to give it, oral or sublingually, which is that's what we call the nitroglycerin. That is what is nitroglycerin is. Okay. Again, it's a good idea to review all these videos again one more time, especially right after we're done with this session, so it stays and you don't forget it. Preload, we talk about afterload, and okay. Blood pressure relation. Okay, map calculation is something that you have to know how to do it now. Okay. Okay. The BNP, okay, AMP increases when there is a problem in the atria. If the atria stretch, it increases. And usually in heart failure, both there's a problem both A and B. But as I said before, the ventricles are more the work of the ventricles is more significant. The symptoms that you see, whether it's pulmonary edema or if it's peripheral edema, it's mainly because of the impairment in the ventricles, not necessarily the atria. So in heart failure, if you order AMP and PMP, you will see both of them are increased. But we don't really care much about AMP because the treatment is guided toward the ventricles and not the atria. Troponin is for the MI. Troponin, so you don't see troponin doesn't increase if the patient only is having heart failure. But if the patient has a history of heart failure and now is having an MI, that's when you see that troponin is high. So if you see troponin is elevating, that is an MI, even if the patient has an underlying cause as heart failure. So the sensitive for heart failure is PNP, troponin for MI. Okay, you need to be able to calculate the map. Again, map when the map is low, that's an indication of low cardiac output also, or low perfusion. And so the map should be within normal. Okay, and a normal map, anything above 70 is give enough uh, a perfusion. And again, in these pressures, it's not the more the merrier. Okay, there's a point where when the map is above 100, for example, or 120, that means the systolic is above 180. Okay, but for perfusion purposes, anything between 70 to 100, that's a normal map. Any questions so far? Okay. Now, the sign and symptoms again of and the physical exam findings, you learn that from the in general in health assessment, and now we're trying to be very specific and how you can interpret. Now you know what kind of conditions causes the heart, and it's related completely to the cardiovascular. The symptoms, as you can see, it's usually cardiovascular or pulmonary, because these two systems are very close and connected to each other. But also you could see systematic symptoms as well. Okay, again, all the symptoms, it's very classical. Here again, a summary of what I just said about the JVD. Now again, this all of them, they mean the same thing, but I'm just giving you an examples of how one concept can also, think of this as a concept map. JVD means overhydration. It means congestion. It means high CVP. It means high preload, and so on. Okay, they all mean the same thing. So JVD is classical symptoms that you see in heart failure. The cyanosis, again, whether peripheral or central, it has to do with decrease of O2 in the blood. Splinter hemorrhage, you will learn about this next week. So we said mainly it's connected to infection of endocardium. This is something you see in endocarditis. You will talk about this next week. Clapping, again, at least you need to know that these symptoms are abnormal and they could be serious. And again, it has to do with the decrease in the blood, the oxygenated blood. The problem in the perfusion, again, if there are ulcers, the healing is delayed because of vascular problems. And this is the classical description of venous versus arterial. And you can just refer that venous is dark and arterial is light, or fresh blood, usually red. Okay, and again, you need to simply understand the relationship between the strength of the pulse that you feel and the strength of the ventricles. So if it's bounding pulse, it has to do either with overwork of the ventricles or too much blood, hyper or overhydration. And then the opposite will be if there's a weak, steady pulse, either the ventricles is weak or there's dehydration, especially if it's fast. And you can just go through all these differences. You need to know that what is normal and what is abnormal. Displayed PMI, you know now, this is classical. The only reason for this displayed is that the ventricles got larger, hypertrophied, and now it's in the sixth, for example, intercostal space instead of the fifth intercostal space. Okay, you know, pitting edema and how to grade that. And capillary refill, and again, if there's change in the diameter because of inflammation, this is the classical symptoms in DVT in the affected leg. And the easy calculation of pulse deficit, which basically apical minus the radial or any other peripheral. Auscultation, again, you must know from now that pre-we always means there's a partial occlusion, and it's always abnormal except in case of if we do artificial fistula for dialysis. But every time you hear a brewery, it means that there's a partial occlusion in that blood vessels that you are auscultating. Okay. Questions? Okay. For the diagnostic test, again, you need to understand each one, what is the indication, what is the interpretation, what you need to report, and what you need to just document. And if there's an exercise, or there's a test that involves the patients to be in there, like in stress test, you need to know what you monitor for, and when you need to stop, and again, the pre and the post care or the preparation of your patient. And again, this is for any diagnostics test. Some of them, they don't have any, there's no need for any pre or post, or could be just minor thing. What do you mean intercostal space? Say the PMI normally it's in the fifth intercostal space, and if you now when you assess the PMI, if it's not on that location, let's say you feel it in the sixth intercostal space, that means that the left ventricles become hypertrophied and large, and that's why the PMI now is displayed. Now it's abnormal thing again, and that's the interpretation of it, that the heart is enlarged, and you can see that in chest X-ray also. Okay, for again the diagnostic test, we talked about the blood test, the CKMB troponin, all of these numbers, they increase in case of MI. But because they could come also from somewhere else, that's why we go with troponin to be the most sensitive, because it's only mainly released from the heart. And we say the ANP and PNP mainly for heart failure, and we say the BNP is the major one for heart failure. You can read about them, and I just want to go over quickly overview. Okay, the ECG again, it's you need to understand again. You all know that this is a non-invasive. It's important that you teach your patient, because the patient may have some misconception thinking that these wires will give him electrical shock, and you need to teach your patient. Let's say the question could be the patient is it's the first time for this patient to receive or to get an ECG, and the patient may tell you give you a few statements, and the question asks you to find which is the incorrect statement. So an example of that the patient needs to be fasting, for example. There's no need for fasting for ECG, or that the patient will need to be in a supine position. No, there's no need, or that the patient will receive some electrical shock during the ECG. No, this is these electrodes. They actually just receive the electrical activities of the patient's heart and put it on papers. Now I know. So anyway, so this is the kind of statement. So you need to know again. There's no preparation. There's no and post-op care or post-procedure care. There's no procedure care, and there's nothing that the patient needs to do other than stay still during the position. That's the major thing. If the patient is seizing or shivering, that will affect the quality of ECG. Other than that, the patient doesn't need to do anything. Okay, and you need to know that it's mainly to diagnose if there's anything with the conduction system mainly of the heart. Now, Holter is another thing that you need to teach your patient about. Patient basically this is a 24 or sometimes longer than that ECG continuous monitoring. Okay, the patient will it's a small monitor that we put the wires on the patients, and the monitor itself, and some of them they actually send live messages or can be received by the physician's unit or physician office, and you can see all the rhythms of the patient live 24/7. And sometimes we just give it to the patient when patient comes back after 1 or 2 days, and we just put in the computer, and then the computer can analyze all the rhythm and tell you where there were what we call events like VTAC or AFib, whatever, any abnormal rhythms. Now, again, you need to tell your patient about mainly how that the patient will need to wear the monitor the whole time. It's taking at least 1 day, sometimes more. Looking for if the patient's conditions is getting worse, or if the patient is using medication. You want to see if these medication are working or not. Patient can just work fine, do whatever they need to do. There's no restriction other than any activities that can move the wires or affect the monitor itself. And of course, no bathing or showering, because that will affect the monitor. And after that, other than that, there's no need for preparation. The patient will need to take their medication because we need to see if this medication are working. Okay, so this is a procedure you don't want to hold medication for. Okay, so this is what patient will be wearing. Yes, go ahead. Oh, okay, let me actually unmute you. Just 1 second. Okay, go ahead, Chris.
Oh, I just want to know when they're wearing the halter. ECG,
Hmm.
do they have to write down their medication so they can correlate the abnormality, if there is, with the EKG with the times of medication?
Yes. When we do that, first of all, we will get the history of the patient and know all the medication that they take, and then we will do a schedule for the medication, ask the patient to follow it. So yes, we have to collect both information, and sometimes we do change the schedule of the patient. Sometimes we add a medication for the patient, and we will have that written, and we ask them to take it as at that time, at a specific time. Again, because it's not a long term thing, usually 1 or 2 days, the adherence is not a problem. But yes, we ask the patient to know at what time they took the medication. Okay. All right. Okay. Mm. Now the stress test. Again, remember I told you about this, that basically we simulate what would happen or how would the heart react, or mainly the coronary arteries, if the patient was under some stress, whether it's emotional, physical activities, medication, smoking. So, because the patient may come into the hospital and now, after, especially after we give them nitroglycerin, you don't see any problem anymore. The But now, so we do this test again. The patient should be able to, of course, do the exercise. So, if the patient has a below knee amputation, for example, they won't be able to, or the patient is in stage 4 heart failure, or for whatever reason, if they cannot stand and they're not stable to run, they won't be able to do it. So the preparation before, again, just we ask the patient light breakfast, just a small breakfast, 2 hours at least before the procedure itself. Again, because when the patient runs, they will lose calories. So if they don't have enough calories, they may pass out because of hypoglycemia. But at the same time, you don't want to give a large meal, because that will also cause the patient, the parasympathetic system will be active, and then the sympathetic system. And again, patient may go in hypertension as well. So as you see, you need to be with the patient the whole time. We have a continuous EKG monitoring and the blood pressure. And after you explain the procedure to the patient, and typically this is what the patient will be wearing, just a loose, fitness, with shoes, and they hold in the bar. And at any time the patient starts to show symptoms of ischemia, such as chest pain, elevation of blood pressure, diaphoresis, all these are indication that the cardiac test is positive, meaning that the patient will have some kind of ischemia if they are under this kind of activities, and that's when we will prescribe nitroglycerin for them to take. So you need to quit the procedure whenever the patient start to show any symptoms of cardiovascular events: diaphoresis, increased blood pressure, changes in ECG showing ST elevation, chest pain. Stop, let the patient rest, and that's it. And they quit the test. Now, post op or post procedure, we just need to monitor the patient for a couple of hours, their blood pressure and their EKG, and after that, that that's it. Now, if the patient cannot run and cannot do the treadmill procedure, then we give some medication that would do the same thing. And if you look at, I talked about them, and again, here I have the pre and post, make sure you know them. And instead of the cardiac test, we can do medication, give the medication IV, and they would do the same thing. Basically, what we do, we increase the oxygen demand of the heart, and you see if the coronary arteries and coronary circulation will be able to compensate for this need, or increase the need in oxygen demand or not. Echocardiogram, you need to know that, first of all, this is a non-invasive procedure. It's used the ultrasound, so it's not an X-ray. So any procedure that use ultrasound, it is safe because it doesn't have a X-ray. So if you have a patient who's pregnant, can use echocardiogram? Yes, because it's ultrasound. It's not an X-ray, so it doesn't affect the fetus. Another thing, again, there's no. Okay, the blood pressure, anything above 160, but again, depends on the patient, baseline. But again, usually when the blood pressure goes up, you'll have other symptoms if it's got had to do with the cardiovascular. What we look at more than the blood pressure is the heart rate. And there's a specific calculation that you have to have the patient goes up to. So the calculation is the formula, just for your information, it's 220 minus the patient's age. So let's say the patient is 60 years old. 220 minus 60 is 160. So you need the patient to go and keep running until their heart rate is 160. At that point, the patient is not having any chest pain or any events. You can stop the procedure and consider that the patient is fine. If the patient, before they get to 160 and they start to have chest pain, you can quit it. Okay. So what, it's not only the blood pressure, it's also what else is the patient showing as far as symptoms. If the patient blood pressure is 160, which is could be 150, 160 expected with exercise, but there's no chest pain, their AKG is normal, then you can continue. All what you need, again, this depends on the patient activity. We have that formula, depends on the patient age. We get the patient to this heart rate. If you 3 or 5 minutes after that and the patient's not showing any symptoms, then you can quit the procedure. And but patients with cardiac problems, whenever they get to that, even before they get to the target heart rate, they start to show symptoms of chest pain or diaphoresis. If the patient tells you they're dizzy, of course you have to stop, even if it's not cardiovascular. But again, it's a safety issue for the patient, and we may have to repeat the procedure. Okay. So what I'm trying to tell you is, you need to keep an eye on the patient and know when to quit and when you need it, so just to keep your patient safe. Echocardiogram, again, use the ultrasound. This is a great procedure because it's non invasive and it tells us so much. It tells you the heart size, the size, the chamber shape, if there's hypertrophy, the valves, if there's any problem with the valves, you can see through the echocardiogram. It gives you the pressure in every one of the chambers. It gives you the ejection fraction and so on. And again, it's non-invasive. You can see the position that we have the patient on. This is the ideal position where the patient should be in the left side. This way you maximize the preload. So if there's any murmur problems or any structural problem, with the increase in the preload, with the maximum preload, it will show. So that's the position there. As far as other preparation, you can read through it. There's no other preparation pre or post. Now, the other one is the cardiac cath. Now, this is an invasive procedure that involves more preparation. Of course, the consent, and you remember now, every time we do an invasive procedure, we have to make sure that the bleeding tendency of the patient is under control. Now, if you see the PT, PDT, INR are high, then you have to report that. Now, what I want to add this time is, what if it's urgent? If we have to do the procedure and it's urgent, we're not gonna just stop the procedure. We need to revert the conditions. So if the patient's blood is too thin, one of the options that we have is giving them fresh frozen plasma. Okay, and we can give that right away from the blood bank over an hour, and then we can repeat PTINR after a couple of hours. The other thing is, if the patient's blood is thin because of Coumadin use. Now you know that Coumadin takes, even after you stop it, it takes about 48 hours for the body to clear it up. But let's say again, if it's an urgent procedure and the patient just received or has been receiving Coumadin, then you can give the antidote, which is vitamin K in this case. And again, this will help in making the tendency of the bleed less. So that's before, and of course the constants and education. One of the major thing about the cardiac, again, catheterization is the the post op. Again, one more thing before. Again, the pre, we talked about the dye and how you assess if your patient is allergic to the contracts and can develop an allergy. Again, and if it's not an emergency, we have to look at a different option. But whenever we have to perform for the benefit of the patient, then we have to think, what else can we do? So for bleeding tendency, we have fresh frozen plasma, we have vitamin K. For allergy, we can give antihistamine for the patient before they go, and so on. That's only if it's urgent to do. Now, during the procedure, you're not going to be there, but you need to prepare your patient what they would expect. Okay, so again, usually this is the question about it is your patient's statements, which one is incorrect and which one indicates further education is needed. So you need to know that what going on in the cardiac cath as far as insertion of a catheter goes to the coronary arteries, goes to the heart, and the patient would expect. I mean, again, the area will be numb. The patient should expect that warm feeling when the contrast is administered, and so on. The major thing is the post-op. Two major things is again getting rid of the dye by increasing the intake of fluids, whether IV or PO. And the second thing is the position of the patient. The patient should not move because the major thing is the bleeding and the renal insufficiency as a result of the dye. Okay, and I have all the preparation before and after. Again, anytime if the patient has a risk for a specific problem, we want to reverse that, and also we want to eliminate anything else that can increase the risk. An example, if the when we give the dye during the catheterization, again, there's a high risk for renal insufficiency. So if the patient has any other problem like medication, like for example here glucophage, that can increase the risk for renal failure, then also eliminate that to eliminate the overall risk. And remember, if you have to stop a medication for a couple of days or so, think about what is this medication, what is it doing, and should it be replaced with something else or not. Now, sometimes maybe not, but a glucophage, for example, for a patient who's diabetic, you don't want to leave them without anything. So if you want to stop it, you give them insulin. Patient who's in synthroid, you stop it, you give them in the different route, IV or any other route that's available if the patient cannot take it orally. So that's another thing important. And again, the post mainly monitor and don't move, pulse. Look for complications basically. Any complications that you want to do all the interventions to prevent complications. Okay. Now, whether the patient has a cardiac cath only just for diagnostic, or whether we put a stent, or whether we use the balloon before and after procedure, preparation is the same. It doesn't change. Any questions so far? Okay. Carrie, do you want to talk about hypertension? Are you there? Okay. You want to talk about hypertension? Okay, I'll unmute you and you can go ahead. No? Okay.
Can you guys hear me? Hello?
Yes, yes.
Okay, cool. Um, so as far as hypertension, we just want to try to remember the different regulatory mechanisms for controlling blood pressure, including like the sympathetic and the parasympathetic, neurological control, and the hormones that control blood pressure. So I think we're all familiar with like the vascular system. We talked about nitric oxide and the endothelium. Hold on, babe. For regulating blood pressure, and the kidneys as far as the renin, angiotensin, aldosterone system, and the how the heart regulates as well as from like the ANP and the BNP. Excuse me, guys. And let's see. It's important to remember the different classes of hypertension as well, because there may be like questions about what stage the patient is in and what the control would be as far as medications. I know you guys had some really good examples for your cardiac medications, blood pressure medications. So try to look at those as well. And I think we also talked about, I don't think we're going to have any questions on hold on, Sean. I don't think we're going to have any questions on hypertensive crisis because that's more of a critical care concept.
Yeah.
But definitely knowing the different regulations for blood pressure control, as well as I think I mentioned antidiuretic hormone and the control from the adrenal medulla. And who's at risk? Mostly with hypertension, you're going to get questions like to understand the diet considerations and the medications. So knowing that the elderly patients are at risk, people who smoke and drink and have diabetes, people who have hyperlipidemia and hypertension, because of high sodium, and then men under the age of 55, those are going to be your people at risk. People who are also obese. Also remember that the African Americans are 2 times more likely to have hypertension than whites. But we kind of talked about this. So questions usually are related to the diet considerations and medications, I guess. Let's see, what else do I want to tell you guys? Knowing the end organ damage, so like the effects of hypertension, like in the kidneys, the eyes, the brain, the heart, and also the question may not necessarily be something related to just knowing that it's kidney damage. It may be interpreting like a lab result, like elevated creatinine can be an indicator of impaired kidney function. So that would be a side effect of your hypertension and showing some signs of end organ damage. Diagnostic tests that are important in the consideration of hypertension. Your electrolytes are important, like in a BNP, to know your sodium levels, and that can contribute to hypertension. Blood sugar for your diabetic patients, urine and creatinine to check for renal involvement, your EKG or echocardiogram that can show like end organ damage effects of left ventricular hypertrophy. Lipid profile can show like CAD risk for your patients if they have high lipids. And remember that your physical exam is important when assessing hypertension. How do you diagnose it? And then it's like the average of 2 blood pressures on 2 or more office visits. And the severity of elevated blood pressure is determined by how quickly the onset is. So if a patient has chronic high blood pressure because of like renal disease and stuff like that, the body's going to compensate for that. And it's going to be almost like they're normal. So the severity really is on how fast the onset is. Like if a person has sudden onset of hypertension, you want to work on getting that controlled faster. And then usually those patients with the sudden onset of hypertension are going to be diagnosed with like hypertension related to secondary causes. So remember we talked about primary hypertension versus secondary hypertension, and primary or idiopathic hypertension usually doesn't have a known cause, and secondary is related to like kidney damage or heart failure, something that's going to cause the blood pressure to be elevated for another reason. There's also like endocrine disorders and pheochromocytoma, some things like that that cause secondary hypertension, but those are more rare. Like 95% of hypertension is related to unknown cause. And let's see. So the ultimate goal for hypertension, I just want to reiterate that, is to get their blood pressure under control, to get them to adhere to some kind of therapy, whether it's like medication therapy, diet control. You want them to monitor their blood pressure, monitor their salt intake, less than 1,500 milligrams usually per day. And a lot of that is found, like sodium, remember that it's found in like canned foods and like, what are those, processed meats. And want them also to lower their cholesterol and their fat, and help them have adequate weight, if that's indicated, if it's related to their sedentary lifestyle or something like that. Also, caffeine can be a cause of hypertension in some people. And let's see, increased physical activity, smoking cessation, decreased alcohol in their diet, and the psychosocial considerations as far as increasing their sedentary lifestyle or something like that. Stress can also cause elevated blood pressures. So, and I mentioned in class that a good table to kind of summarize a lot of the medications was 33-8. I hope you guys all got a chance to look at that. It talks about like the diuretics and the direct acting vasodilators, your ACEs and ARBs, your calcium channel blockers, and stuff like that. So when in the treatment of hypertension, you talk about primary prevention, which is doing your, like, did somebody ask the question? Oh, it's not a page number, it's just chapter 33, and it's table number 8, 33-8. Did you guys get that? Okay, cool. And your expected outcomes for the treatment of hypertension: to achieve your blood pressure goal, accept and implement, have the patient accept, implement, and understand your therapeutic plan, and experience minimal side effects from the medications and treatments and stuff. So, any questions? Sorry, I'm outside. I'm kind of cold. I'm like shivering. No questions.
Okay.
Hypertension is not too difficult. Also, if you wanted to look at some nursing diagnosis, I mentioned in my notes here a table 33-12. So, and I highlighted a couple of them for nursing diagnosis for hypertension. Would be like anxiety, risk for impaired perfusion, and then you can also do stuff related to like what's the cause, like the cardiac or kidneys or impaired perfusion and stuff like that. But oops, I don't know what I just did.
Okay.
Okay.
Thank you. Alrighty. I'm gonna unmute you. Mute you. Okay. Coronary artery disease. This is one of the most common problems in cardiovascular that actually leads to death. And again, just like any other organ, the heart, it has its own circulation, and of course it's a very serious circulation because every cell in the body depends on the circulation. It comes from the heart. So again, this refers to the coronary arteries that are on the outside of the heart, and their major function is to perfuse the heart with the required blood. So any problems in these coronary arteries will be manifested as heart issues, either in the ECG, in the conduction, the heart, in the ability for the heart to push the blood, and so on. Now, like any blood vessels, they have the same structure, internal structure that should be open and patent, and any factors that affect the patency of this diameter of the blood vessels will be a risk factor, such as atherosclerosis, hypercholesteremia, diabetes, and so on. And also we have the outside structure, and that's basically the smooth muscle. So we should have a balance between vasodilation and vasoconstriction. So the mechanism of the coronary arteries problem again, it's mainly the obstruction, whether it's a partial or complete obstruction. Of course, complete obstruction is worse. And so first of all, you need to know who is at risk factors, and basically any lifestyle or any abnormalities that affect this circulation in the blood vessels, whether in the as a result of a spasm, such as using drugs, the illegal drugs, or hypercholesteremia or hypertension for a long time, or smoking, any of these factors that affect the coronary arteries. The other thing that you need to know again is the manifestations. Again, ischemia. Now you know what ischemia is: basically pain as a result of accumulation of lactic acid, which is irritating to the nerve endings, and that you know that cells they go or they switch to anaerobic metabolism, which will result in the lactic acid whenever there's a lack of oxygen. The major problem, if you want to um, summarize the pathophysiology of uh, coronary artery disease, it's basically there's an increase in demand for oxygen, and the coronary arteries are not able to compensate for this increase. So there is more demand than supply, and that's where the cells will switch to anaerobic metabolism. Okay, so let's see. What I got here. Okay, we talked about the pathophysiology. Again, it's important to be able to differentiate between the angina types. Stable means it can be stabilized. Less than 5 minutes, nitroglycerin or rest will take care of that. If it doesn't respond to that, if it's longer than 5 minutes, if it doesn't respond to nitroglycerin, then it is not stable angina. If there's no, it could be unstable angina or it could be an MI. The differentiation between unstable angina and MI, or between MI and anything else, is the elevation of troponin. Done. These are the major thing. Again, if it responds to nitroglycerin and rest, it's stable. If it's less than 5 minutes, if it doesn't, it could be unstable angina or MI. Troponin is negative, then it's unstable angina. Troponin is positive, then it's an MI. And of course, the treatment will be different. You need to know how to evaluate the pain of the patients, and again, the correlation or the changes in ECG that's correlated with different kind of angina. Again, if there is an ischemia, which you could see in angina. Okay, if the patient is having chest pain that responds to nitroglycerin, or it doesn't last more than 5 minutes, it can be relieved by rest, then that's called stable angina. It can be stabilized. If you tried nitroglycerin and rest and still the pain is longer or continues more than 5 minutes, then it could be, again, it's definitely not stable angina, but it could be unstable angina or it could be an MI. That's when this patient comes to the ER, we will run troponin. Now, if the pain is there, but there's the troponin is negative, well, you can rule out MI. It's not an MI. But if the patient is, if there's a troponin, if the troponin is high and keeps going up, then that's an MI. So you need to know, again, differentiate the different types of changes in ECG as far as how it affects the heart. So you know that T wave inversion is ischemia, ST elevation is injury, and the Q wave is necrosis, which is the most serious one. We talked about the treatment monas. You need to know what everyone stands for and what is the regular dose and what kind of instruction you give to your patient. So nitroglycerin should be sublingual, not orally. Aspirin, the patient should chew it before they swallow it. And of course, you need to know why, because we want a maximum and a quick absorption of this medication go through the blood system. Hypoxia, you need to know that, oxygen, how you decide on oxygen, how much oxygen you give. Always look at respiratory and SpO2. Pain, we give morphine, and why morphine, and what's the benefits of morphine, and when you would stop, when you would hold morphine, and what you would look for after you give morphine, and also the complication, what kind of complication you have to keep an eye on. And I have all that in this table. And okay, We talked about nitroglycerin. You will hear the word nitroglycerin probably every week. Okay, let me try do that. Mhm. It did not. Okay. Well, hold on. Okay. Hello. Okay. Usually. So, okay, we talked about that. Talk about the medication. Okay, yeah, education of your patients, decrease of the risk, what they can do and change in their life. Also, and or in as far as risk and who's at risk, also you need to differentiate. You may have four patients with risk factors, but there's some are more serious than others. And again, if the patient has multiple risk factors, then their risk is highest. For example, if your patient is older, with from a black ethnicity and has hypercholesteremia, there he has higher risk than somebody who is Asian and with normal um, cholesterol, but maybe a smoker. Okay, so the more risk factors, the highest the risk. Okay, and how we talked about the differentiation with unstable angina, and then what is the difference about silent angina where you see it, and variant angina mainly has to do with the spasm. Usually, this patient doesn't have any; they don't have any atherosclerosis problem, it's just a spasm. So it's coming from the outside, so the inside of the blood vessels might be normal. So, and usually you see it with it has to do mainly with drug use. And the silent angina, that's when your patient has symptoms. You see it in the chest in ECG, but the patient denies or doesn't experience the chest pain, and it has to do with the neuropathy. Talked about that. Again, MI, we have ischemia, we have injury, and we have necrosis. You know, necrosis is more serious, injury, intermediate, and the ischemia is the least um, serious. Again, if you have four different ECG and you see one with ST elevation and one with Q wave and one, sorry, I know I'm probably making you dizzy here. Just a second. ST elevation versus a Q wave, deep Q wave, Q wave is more serious. T wave inversion versus ST elevation is more serious. So if you have four different rhythms and the question asks you which patient should you see first, then it will be the one with the more serious, which is the Q wave problems. Okay. talk about the location, but I don't want to require this for you for this semester. But basically, in a 12 lead ECG, you can think of it as a 12 shots. Okay, there are 10 cameras, 10 wires, and they give you 12 shots and or 12 images. We put them together, but each camera is located in a different wall of the heart. ST elevation is more serious than T wave inversion, but it's less serious than Q wave um, enlargement or a deep Q wave. So the least serious is ST. The least serious is T wave inversion. ST elevation is more serious, and the most serious is the Q wave problem. Okay. So again, in coronary artery or acute coronary syndromes, we refers to that basically any events like stable angina, stable angina, unstable angina, MI, and then we do all these tests to differentiate if whether it's stable or unstable or if it's an MI. So you need to know what to expect in everyone. Again, T wave inversion or ST or Q wave. And the treatment, you need to know which one requires a treatment. So stable angina, nitroglycerin, sometimes one sublingual nitroglycerin will take care of that. For unstable angina, they may require more than that. It could be a drip, it could be multiple dosage. And for the MI, either cardiac cath or fibrinolytic therapy, where we give TPA. So you definitely need to know that TPA is not something required for for stable angina or for unstable angina, or even for non-ST elevation MI. It must be ST elevation MI. And so this is just a summary, again, helpful summary here of the changes and the medication. For any medication, for any therapy, you need to know the possible complications, the difference between side effect and adverse reaction, because that's when you decide if you just monitor or if you have to quit. Okay, so for TPA therapy, mainly it's the bleeding. TPA is only indicated for ST elevation MI only. It must be MI confirmed by elevation in troponin, and it must be an ST elevation in ECG. Okay, other than that, if there's no ST elevation or if the troponin is not high, TPA is not indicated. Then you need to know who's is candidate for TPA. A patient who's have high tendency to bleed, whether they've been receiving Coumadin or they have recent surgery or recent stroke, they shouldn't receive it. Okay, and of course, while it's being administered, again, I will just be general about it because you won't be giving TBA or even seeing TBA in med-surg, but again, more details in critical care. But you must know that mainly it's the bleeding that is the most serious complication of the TBA, and that we want to monitor it for that. Okay, this is the eligibility, who's eligible, who's not. And again, keep an eye on this patient, and then we give them also, again, heparin is always, in case of thrombosis, heparin is only given to prevent further thrombi. And again, if we have to do a catheterization, cardiac catheterization, we talked about the pre and post preparation and intervention. And as far as the assessment of complication, and ask the patient not to move their legs to prevent bleeding, and again give IV to hydration to get rid of the dye. Questions? Good. Okay, well, let's move to heart failure. Can you repeat the order of? Okay. T wave inversion, okay, ST elevation is more serious than T wave inversion. Q wave, long or deep, is the most serious ECG changes. Okay, so it will be T wave, then ST, then Q wave. Remember we talk about if the Q for a queen, if they reach the queen, game is over. Okay, let's think. In fact, in ECG, always if the Q is involved, it's serious. So a QT, for example, QT, a long QT is serious, and that can lead to the sudden or put the patient at risk for sudden cardiac death. If the Q is long or deep, again, that's an MI, necrosis. So it is serious. So whenever the Q is changed, whether it become longer or deeper, it's also serious. Okay. In the treatment, of course, for T wave inversion, for example, if you give just oxygen, that could help. For ST elevation, if it's an MI, if you give the TPA on time, or if we do the cardiac cath on time, also the patient will be fine. But if it reached to the Q, that means we're kind of late. It is very serious. Okay, now
Okay, we will
oops. The heart failure, again, this is it's a very important disease, and it has so much that you can learn from, because all the hemodynamics terms that we used before, you can actually see it in heart failure, and you have to connect it all together. So simply, heart is failing, that means the heart is not doing its function, and the heart failure could be, again, before of fail to receive or fail to push. You need to differentiate between right-sided and left-sided as far as the clinical manifestations. As I said, if the problem is in pushing, then the manifestation will be in the back. So if it's left-sided heart failure, what is in the back is the pulmonary circulation. So that's why the patient will show mainly pulmonary symptoms like pulmonary edema, cricos, orthopnea, dyspnea, and so on. If it's on the right side, again, if the heart or the ventricles cannot push, the problem will be in the back, because there's a backup. There's congestion, so you'll see it peripheral edema, JVD, elevation or enlargement of the blood. Enlargement of the liver or spleen, and so on. Now that's one differentiation. The other differentiation is between systolic and diastolic, and it makes sense if you think about systolic means that it's pushing during the time of pushing blood, and diastole during the time of receiving blood. So one of the major differentiation between them is, number one is the mechanism. The change in it is that the wall become very thick in case of diastole, and that's why the patient doesn't receive enough. The container size inside is now less, and the systole is the wall become very thin in attempt to receive more blood, so the ejection fraction will be low. Again, the other thing is the ejection is only take place during systole, not diastole, so ejection fraction will be low. When the ejection fraction is low, then that is a systolic heart failure. And again, the low here, the cutoff point is 40%. So when the ejection fraction is below 40%, this is a systolic heart failure. The ejection fraction doesn't change in diastolic heart failure. So again, to know who's at risk, MI is one of the most common, actually, cause of heart failure. Let's see what else I want to highlight. Pathophysiology, mainly you have to understand that should explain the manifestation between right and left side heart failure. So I said MI is the most common cause of heart failure. Okay. Um, Again, you need to understand the pathophysiology. All these terms can be replaced by more of a clinical measurement. So elevation in the right atrial pressure also means that there's a high preload. Also, it means that there's a JVD will be there, and so on. And for the left side heart failure, a low cardiac output means low ejection fraction. Also means that the patient will be fatigued, means that the renal perfusion will be low, means that it's expected that the urine output will be low, and so on. Okay, and we talked about the different types between dry and warm. Again, we say dry, there's no fluids, no edema, and warm, there's a perfusion. While cold, the perfusion is low, and wet means there is a fluid, and what we mean by that is the edema, whether pulmonary or peripheral edema. And again, here's the differentiation between left side and heart and side. And again, I give you more explanation of why the pulmonary edema versus the peripheral edema. And the noxious dyspnea, we talked about the position and how that you need to explain that to your patients. So if the patient experience this kind of symptoms, you want to tell them, you can't tell them you can sleep, but of course if they sleep, they need to use several pillows to keep the fluids away from the lungs. Classification, the more advanced the stage, the worse the symptoms, and you need to know what to expect to see in patient with heart failure. Again, A and B and P and B. In case of the acute stage, when the patient comes to the hospital and sick, it will be high. ECG, you would see changes because of the enlargement mainly of the heart. You see that also in chest x-ray. You see a large heart and maybe pulmonary edema if the patient has left-sided heart failure. In echocardiogram, we look for the ejection fraction that we expect it to be low. Um, Especially, of course, it will be low in systolic heart failure. If the patient has angina that comes because of heart failure, we may need to do a stress test or cardiac cath. This only done if the patient has angina pain that's caused by because of their heart failure. We talked about what you would expect to see in CBC, and I have a full explanation of that. We went over it. Why the patient would have anemia, why the patient would have in changes in the renal perfusion can lead to renal impairment. You may see high creatinine and so on. And again, with ABG's changes, we talked about echo and the different kind of echo preparation before and after, and the management. Again, every medication, why the patient would need to take digoxin, why Lasix, and now you understand all that. So you should know what the patient, again, when should you stop or hold a medication and or not. But again, simply you need to know why the patient should gets nitroglycerin, and why Lasix, or why potassium. So before you give Lasix, what you have to check and assess before. It's all is connected together. Okay, okay, and this is from the farm. We put them all together. We talked about it several times. And okay, let me see if you have questions about heart failure in general, either treatment or the pathology or the differentiation in symptoms. No questions? Okay, I would say that heart failure is heavy in NCLEX and MedSurg in general. So um, probably there will be 10 questions in the exam on heart failure. So make sure that you understand it well. Okay. And I think heart failure I like it because there's a lot of sense in it. So just you need to connect all these together. Okay, the last thing is the dysrhythmia, and I'm just gonna give you the hints that I shared before. It's not You are not required for to know the advanced rhythms at this point that's left for critical care. So I just want you to be able to recognize, and I know some of you have a concern about some of the rhythms are different or not very clear. For the exam purpose, it will be clear, and I use the same rhythms that I use in the modules. Okay. Now, for more practice, you have the book, the ECG Made Easy. You can look at that and practice more. But for the exam, just I will use the same kind of examples that the same system that I use, some program, because it's kind of clean ECG, and I like to use that at the beginning, and then um, later in the critical care, I'll give you the more complicated and more confusing kind of ECG rhythms. But for now, again, you need to know the four sinuses, and of course, there must be a P wave. So again, just follow the algorithm. The first thing you want to look at is see if there's a P wave or not. If there's no P wave, you already eliminate several rhythms. No P waves mean that they're non-sinus, so there are four rhythms there that you eliminated. They're not AV. There's five rhythms there, or actually six rhythms between AV, first degree, second degree, type 1 and type 2, and third degree, and junctional. So if there's no P waves, you're down to either atrial or ventricular. The second thing you look at is the QRS. If the QRS is wide, then you want to think of the ventricular, and then you look at the heart rate. Now you can follow the criteria that I give you. You can apply all of them, but they don't always apply. Not everything. Some of the rhythms you can just look at it and you recognize it. When you talk about asystole or VFib or VTAC, this is three by morphology. By looking at it, you should be able to recognize it. Now, the one that needs more work, if it's sinus or atrial or AFib, or sorry, AV blocks, and that's when you need to know all the criteria. Of course, you have to memorize it, and you will apply it. So what you would do, what I would recommend for you to do when you see the rhythm, and you can use scratch paper in the exam, and try to again follow this criteria to eliminate. Okay, because all what you have four sinuses, you have five junctionals, and you have two atrial, and so that's 11, and you have three ventricular, including asystole. Okay, and you will have four options. Don't look at the options, look at the rhythm and try to apply the criteria to reach to what is most likely is, and then you look at your options. The second thing is the other way, you could take options one by one and see if that option fits. So you look at the rhythm and say, okay, I have sinus bradycardia, sinus tachycardia, AFib, and A flutter. So you can take one at a time. So you look at A flutter, you look at the rhythm. Okay, well, I don't see that sawtooth thing, so this is not A flutter. The second thing you look, okay, AFib, you look at the rhythm, you find it regular, you right away you exclude the AFib. Now you're down to sinus tachycardia or sinus bradycardia. So just go with the heart rate, you're done. Okay, I know that I make it sound simple, and ECG is not, but at this level, that's all what I want you to know, and then we will build on that in the second semester or second mid-surg, and also in critical care. So these are the two ways that you can again know the rhythm, either by taking the options one by one and see if they apply or not, or you take the rhythm, ignore the options, do the rhythm first, which I prefer that way, and then look at the rhythm and find it. Now, if you come up with a rhythm and you don't see it in the options, then you want to question your interpretation. Go back and try, or now you can use the second way by taking the options one by one. For rhythm and for any MCQ questions, always there's one question, one option that's completely out of the picture, so you can eliminate it right away. Now, assuming that again you know the contents, so you're usually down to three. Then you can apply the strategies of, okay, if both of the options mean the same, then both are wrong, or if two are completely opposite, it's likely that one of them is the answer. Now, you only apply these strategies if you don't know, if you're completely unsure of your answer. because if you apply it for every questions, you will find that, oh, you're getting wrong answers. So first, always depends on your understanding and your knowledge, and then you look for strategies if you are not sure or if you have two possible options, and always go back to the question and make sure to that you understand it. So again, one more time, for the rhythms, there are only 13 options, and I know that that sounds a lot, but they share the same thing. So when you see, when if you look just at them before you even apply any criteria, if you look and you see that the QRS is narrow, that cannot be ventricular. So there are three already out. If you look and you see don't P, there's no P waves, there's 7 already out, and so on. So do it by exclusion. Okay, questions? Did you want me to go over the rhythms that we have in the module, or are they clear? Okay. Okay. Okay, now today we will talk about one of the most exciting topics in cardiovascular. Okay, so for the calculation, the heart rate, again, you should be able to calculate it. And again, I give you several methods. And I told you you can pretty much always use the easiest one, which is number of R star times 10. Is there any question about that one? Okay, and then you need to know the boxes, that small box equal 0.04 seconds, and 5 of them, which is a big box, is 0.2, because this is when you try to determine the PR distance, and or if it's a Q problem that you're going to look at. Okay, so again, here's how, one big box is 0.2, one small is 0.4, and then as far as the vertical is 1 uh, 1 millimeters each small box, and a big box is 5 millimeters. Okay, here's the heart rate. So I talked about these methods where basically you find a QRS that's exactly on a thick line, and then you need to memorize all these numbers. So that's why I don't like this one. And then the other method is basically find two R's, regular R's, and count the small boxes in between divided by 1500, or the big boxes and divided by 300. And I give you an example here on how many small boxes or big boxes divided by 300 divided by that number, or a different one with you count a small one and then 1500, and gives you close the same kind of heart rate. And the easiest one was whether regular or irregular, to just count how many R's and times 10, and that give you an estimation of the heart rate. Okay, sinus rhythms. Okay, let's start with the sinus. Okay, and sinus. I'm just gonna talk about the criteria of each one. Okay, normal sinus rhythm. This is your baseline that you will apply and compare any other rhythms to it. It has to be the heart rate should be normal. It must be regular. It must be a P wave. Only one P wave before every QRS. So the ratio is 1 to 1. The PR is 0.12 to 0.2, which is 3 to 5 small boxes, and the QRS should be less than 0.12, which is the 3 boxes. So as you see here, his heart rate is normal. Each peak is followed by a QRS, so the ratio is 1 to 1. And the heart rate again within normal. And then later when you watch this, you will see that everything is within normal, and that will be sinus rhythm. Now, after you understand sinus rhythm, for the sinus bradycardia, only one deviation. Everything is the same except the heart rate. For the sinus tachycardia, the same thing. Everything is normal, but the heart rate is above 100. And for sinus arrhythmia, everything is normal, but but it's just irregular rhythm. Maybe one beat that it was just because of respiration or sigh or whatever that make the rhythm irregular. Otherwise, everything is within normal. There's a P wave followed by QRS. Again, the rate is within normal. It's regular rhythm, and it's not ventricular. As you see, the QRS is within normal, and then the PR from the beginning of the P to the beginning of the QRS is also normal. Okay. So again, if you go back and watch these videos, I go in details in every one and what is the criteria that will make it normal, or what will kind of deviation that will make it abnormal. The atrial dysrhythmia, again, two types of them that we covered here only, the AFib and the A flutter. Again, since an atrial, that means that there's no P wave because it's not coming from this SA nodes. And the other thing is the shape here for the atrial flutter, the shape of what supposedly need to be, it should be a P wave. It's not really a P wave, but just happens to be before the QRS. The QRST is normal, so the problem is with the P. There's no P wave, and you can see the shape of the what we call the F wave, and usually it is regular for the F flutter. And there's a major difference between it and between the atrial fibrillation, which is one of the most common dysrhythmia. You can see just by looking at it, it's irregular. So when you have irregular, right away think of fibrillation. And then the second thing is you can see the fibrillation here, and you can see that the QRS are normal. So it's not ventricular, it's not sinus, it's not junctional, it must be atrial. Well, since the shape of the uh, waves is not that sort of things, then this is atrial fibrillation. Now, if you want to apply the criteria one by one, you can. If you look at the heart rate first, 1, 2, 3, 4, 5, 6, 7, 8, 9, 90. So that doesn't help anyway, but it's within normal. The second thing is the regularity. If you can see the distance from here to here is way bigger than the distance from these two R's. So this make it irregular. Since it's irregular, it cannot be sinus tachycardia, it cannot be sinus normal sinus rhythm, it cannot be sinus bradycardia. And again, since there's no P waves, then it cannot be sinuses. So all the sinuses are out, all the ventricles are out because of the QRS. All right. It's not junctional because the PR, it's not junctional because there's no P. And it's not AV again because there's no P. Okay, so just no P excludes all the sinuses and the AV and the junctional. You are down to atrial or ventricular, and because the QRS is normal, so it's not ventricular, so you're down to only the atrial. There are two types of atrial. Since this is always irregular, it's most likely AFib, and then since there's no sort of waves, then it's AFib. Does that help? Okay. The junctional, again, one thing, your start is a P wave inversion. That's your start. You only see P wave inversion today. That's for this class. You only see P wave inversion if it's junctional. So as soon as you see a P wave inversion, you exclude. Now let's move to you exclude everything but junctional. Okay? As soon as you see a P wave inversion, again, you exclude everything but junctional. This cannot be anything but junctional. Now, the next step is just to see the heart rate. If the heart rate is below 60, it's escape. If it's above 60, it's accelerated. That's it. So, as soon that's what I'm telling you, that you can, when you see them in that question, either analyze the rhythm or start with the option. But if you look at the rhythm and you can see clearly here is a P wave inversion, you're done. Look, you can, just by seeing that, go ahead and look at your options. You most likely will see two junctional and two non-junctional. Exclude the non-junctional right away. So you have two junctionals. You have to differentiate between both of them. Mainly it's a heart rate. Calculate the heart rate, you will know it. Now, the other one is the AVs. Now this one, when you see them, it will, as well as the sinuses, they need a lot more work. So first of all, if you look at the rhythm, you find there's P waves. Since there are clear P waves, then these are not atrial and they are not ventricular. So they are either junctional or sinuses. That's number one. Number two, when you see that the P wave is not inverted right away, you exclude two junctional, escape and accelerated. So we're down now to four sinuses and three AVs. Okay, the next thing you look and you see the heart rate, 1, 2, 3, 4, 5. What do you mean no visible? Yes, it's actually inverted, but yeah, it's either clearly inverted or you don't see it because it's embedded with the QRS. Yes, but everything else is normal. Everything else will be normal. So if you see everything is normal, but you don't see a P wave, but it's not a, there's no P wave, there's no flutter waves, and not necessarily because the QRS are normal. The QRS, there's no ventricular problems here. It's mainly the junctional. No, the QRS will be fine. Okay, so again, we found okay. There's a normal P wave, normal shape is not inverted, so excludes atrial, ventricular, and junctional. I have only four sinuses possibility and three AVs. All right. Let's see. The next thing you want to look at again, the heart rate. 1, 2, 3, 4, 5. So with this heart rate, I exclude the normal sinus rhythm, the sinus tachycardia, and the sinus arrhythmia. Already with the second step, I excluded three. So what's left now is sinus bradycardia, because the only one that has low heart rate, and AVs. Okay, so I still have four options. Let's try to exclude. The next step is the PR interval. So if you measure the PR from the beginning of the P to the beginning of the QRS, you will see that it's longer than 0.2. So that will automatically exclude the sinus bradycardia, because in sinus bradycardia we have everything normal but the heart rate. So now I'm down to the three AVs. Okay, as you see, each P wave is followed by one QRS, right? 1 to 1, 1 to 1, 1 to 1, 1 to 1. So that excludes type 2, AV second degree, type 1 and 2, they're out, as well as type 3. So I'm down to AV first degree. So if you follow the criteria, the whole idea of this criteria is to exclude, not to memorize. As you see, the heart rate will help you exclude many. If the heart rate within normal, then you exclude the sinuses. You exclude the tachy and you exclude the brady. If the P wave depends on its shape. A normal P wave exclude the atrial, ventricular, junctional. PR, PR, it's a classical. It only distinguishes the AV. If the PR is longer than normal, exclude everything but the AVs, and so on. And then you just need to know for the second degree, they're basically one P that is blocked and it's not causing a QRS, while in the second degree, type 2, there are multiple that being blocked. And in the third degree, all of the P's are blocked, and so none of them is creating a ventricular, and that all the ventricular, the QRS that you will see, they're actually coming from the ventricles and not, and there's no association between the third degree P waves and QRSs. So again, think of the criteria and what they distinguish. Heart rate, sinuses, normal, heart rate, tachycardias, bradycardias, or normal. PR, distinguish the AV, period. P wave, if it's normal, it goes with AVs only and sinuses. If it's inverted, only goes with junctional. If it's not there, it could be atrial or ventricular. Okay, PR to QRS. If there's a P normal, of course. If there's 1 to 1 PR QRS, it's either sinuses or AV. The distinguish will be between them is depends on the PR interval. QRS, if the QRS is wide, it's most likely ventricular. And then for the two ventricular ones, just by looking at them, a wide QRS that's regular and wide looks like this. This is a VTAC, I'm sorry. The rhythm that doesn't have anything in it, it looks very irregular, very bizarre shape, with no P. You can see P's, you can see QRS's, you can see there's no heart rate here. This is the classical shape of the VFib. So this one you don't need to apply anything, any of the criteria. Just by looking at it, you should be able to identify it, knowing that the VFib, and of course the straight line is asystole, and okay, I don't want to complicate it. Just the straight line is asystole. I'll add more rhythms later. Now the PVCs, the PVCs basically, again, you have could be a normal sinus rhythm, but there's one beat there that comes prematurely. Again, for premature ventricular contraction. So ventricular means that the QRS, premature means that it fires before its normal timing. And so this is not a rhythm. This is what we call ectopy. So if I give you a rhythm and I tell you just to identify the ectopy, all what you need to know is just, okay, this is the shape of PVCs because it's wide QRS, then it has to be ventricular. And you see here, there's a PQRST. This is the normal beat, but right here you don't see a P. So the QRS fired or showed up prematurely before even did not wait for the P. So there's no P, as you see, that created this PVCs, and that's why it looks different, because this is a normal QRS that is caused by a P wave, as you see it right here. The ventricles decided not to wait for a sinus P to cause it, and then so this is how the ventricular contraction looks. They're always wide. So again, as soon as you see this shape of a contraction that is apparently prematurely, because this is a T and there's no P, so it's fired by itself, then this is a PVCs. Now, just the classification again, as you see, there's this is another shape of the PVCs. So if you have them and look in different shape, we call them multifocal, which means they come from different areas, but they both are premature with no P waves of preceding. If they couple of them followed each other, we call them couplets. If there are more than three of them, it's become ventricular tachycardia. And if it happens every second, we call them bigeminy. If it happens every third, we call it trigeminy. So normal, normal, one normal, two normal, third is PVCs, and it's tri. If it was normal, then PVC is normal, PVCs, then it's bi. As simple as that. Okay. Alrighty. And as far as the cardioversion and defibrillation, again, we talked about the treatment. You needed to know just the basic medication, like atropine. Know that atropine will elevate the heart rate. So you will never give atropine for anybody with normal heart rate. It has to be below normal and symptomatic. You need to know that the baseline of the patient. If the patient's is baseline heart rate is 55 and they have no symptoms, then we're not going to do anything about it. But if you have a patient with heart rate now is going down to 45 and the patient is a little lethargic, and the blood pressure is low, then these are symptoms. Then you have to give a medication at that point. Okay. The other medication we talked about is epinephrine, and that's giving again during CPR. And the thing is that the last thing is a defibrillation, which basically shocking the patient, and that's only indicated in two cases: ventricular tachycardia with no pulse and VFib. VFib, there's always no pulse. So if you see a VTAC on the patient, we have to check their pulse first. If they have pulse, we give a medication which is lidocaine. So lidocaine is a drug of choice for ventricular dysrhythmia in VTAC. If you see a VTAC and you check the patient and there's no pulse, then you need to shock. So only two shockable rhythms. You must know that. Only two shockable rhythms. VTAC with no pulse, not VTAC alone. VTAC with no pulse and VFib. It's just anything else is not shockable. And then the other thing you need to know the difference between cardioversion and defibrillation. Okay, we use the same machine. We just have two different modes. A mode for defibrillation, that's when we deliver high energy. It's higher energy than cardioversion, of course. and it's only indicated for VTAC with no pulse and VFib. Cardioversion is mainly indicated for tachyarrhythmias, like AFib or VTAC with pulse that is not responding to medication, or SVT. Whenever the heart rate is very high, but the patient has pulse and is not responding to medication, then we can do the cardioversion. The major difference between cardioversion and defibrillation, again, is the indication, and second is the amount of energy that we deliver to the patient, and third is that cardioversion is given to a patient with pulse, and that's what the major term that you must know when we talk about cardioversion is the synchronization. So we synchronize the electrical activities with the QRS. So the electrical activities from the machine is delivered at a very specific time and should not, otherwise we can cause more problems. So, and what the cardioversion does is basically just hitting the areas in the atria, okay, that causes the QRS's, contraction to stop it from firing. So remember, for example, for AFib with RVR that's not responding to medication, or SVT or VTAC, the problem is, for example, in AFib, there are multiple areas in the atria that's firing at the same time, and that the ventricles are responding to it. So if we fire some electrical activities again from the machine just before the QRS, that's why we time it with the QRS, it will hit the atria areas that causing all this extra firing, and that electrical activity will inhibit this electrical impulses, and then that's how we convert. That's what we call cardioversion. We convert it to a sinus rhythm by inhibiting all these areas that's firing and let only the SA do the job. Is that clear? Always, always in, yes, defibrillation, uh, that you only give it when there's no pulse, and that the only two rhythms that when you won't find pulse is VFib, always there's no pulse. VTAC, you must check first. Yes, and cardioversion, yes, you give it to a patient with pulse. They have to have a pulse, and then that's why we synchronize with the QRS. When I say pulse, I mean QRS, because that's what's causing the pulse, is the ventricular contraction. Okay? Any question? Okay. Well, I will wait for the system to convert the videos, and as soon as possible I will put it in YouTube. I will send you the link. You can go back and review it if you need. Just go over what we had, and just do the case studies again, and you should be fine. All right, you're welcome. So if you don't have questions, we can just conclude it. And if you still have a question, you can send me emails. Um, you're welcome. For as far as the modules for next week, I'm working on them. So I know you will be working on your exams for this weekend. So if we don't get them done, we can just work together on. What about tomorrow? You mean for farm? I thought you said you guys had a review and you said you don't. Um, I asked some of you, said that the review was fine, and you told Professor Davis that you don't need a review. How many? Okay, how many of you would need a review for farm? Yeah. Okay, I mean we could do that. I'm just a little hesitant because I'm not writing the exams this time because I didn't give any of the lectures or the classes, and to be honest, I'm not sure on what to focus. So I'm not sure how helpful it'd be, and I just don't want to um, confuse you. Okay. Okay. So I can't say yes to that, but I assumed that was the case. I assumed I talked to her yesterday and say that it was that you clarified what's going to be in the test. Antibiotics not going to be there, and whatever was focused on Friday on your meeting on Friday, that what we needed to focus on. I mean, again, I'm happy to do the review and just don't want that review to be to have the opposite effect, since I'm not writing the questions, or I'm not even sure what was covered exactly. And so I am reviewing the test, yes, but not soon. I would just want to make sure what I review when I review a test with anybody, just to follow the standards of nursing questions, not for the contents. So let's yeah, and hmm. Anyway, uh again, the deal was yesterday that you guys will decide if you need a review or not, and I was told that that was enough your meeting. So bye. uh okay, let me see what I can do. I hmm. No, it is let me think about it. Let's just not do it tomorrow. I want you just to study, and let's see if I can do a one before, maybe the night before, the morning before, but let's see how it goes. Okay, let's see how it goes. I have a good feeling that you'll be fine. I just don't want to step on anybody's toes, and again, I am not sure how helpful the review will be. And what I wanted to do originally is to actually do the review together. I just wanted to do the review together with Professor Davis because I was not sure what was on it. But I will. What I can do, what I will do is just to make sure when I review the test that it's within, it's the style and the expectations of the nursing style, so it won't be tricky or confusing or wording wise and all that. But make sure that you study the contents and understand the whatever was covered in it. But and don't worry about the test. I will make sure that the test is within the standards, will be clear. Okay. Yeah. Okay. And I do that with everybody. So um, supposedly I'm the expert of the nursing questions, so I'm just making sure that they meet the standards. Okay. All right. Well, I hope this. Thank you. I hope this was helpful. And again, we will continue to do it as long as you need it. And I'll see you next week. You're welcome. All right. Bye bye.